All right, thanks, Megan. Obviously a really important topic. Great job. So I have the pleasure of introducing our Grand Round speaker today, Dr. Kelly Williams. And for those of you who don't know Kelly that well, she was actually born in Bangor, Maine, and grew up in Maine for her first 18 years or so. Kelly then went on to do her undergraduate training at Colgate University, followed by her medical school training at Tulane University School of Medicine in New Orleans. And Kelly being Kelly, she impressively folded in a Master's of Public Health at Tulane as well during that stretch. And I should say, during that time, being in New Orleans made her a diehard Saints fan, which she has since passed along to both of her children. And I learned this morning that her son, Grant, actually yesterday had an adenoidectomy and tympanostomy tubes placed, and he is watching his mom on TV this morning. So a quick shout out to Grant watching at home. Hope you feel better soon, buddy. So I first met Kelly back in 2008 when I was chief resident here, which seems like a lifetime ago. I remember she and Conrad were interviewing for their peds residencies, and Mike Southgate and I talked afterwards about just how much we hoped that we would match them. We were largely talking about Kelly, but Conrad was a bonus as well. Shout out to Conrad watching at home also. Honestly, we were incredibly lucky to match the both of them, and Kelly finished her peds residency here in 2012. While she was here, Kelly developed a passion for allergy and immunology and impressively went on to the National Institutes of Health to do an AI fellowship, which she finished in 2015. Since 2015, Kelly's been practicing her AI craft here at MUSC, and she is also the medical director of our pediatric ambulatory infusion, which I know she's working really hard to streamline at the Summit Medical Pavilion. Kelly has authored a remarkable 22 publications on topics ranging from pneumococcal vaccines to hyper-IgE syndrome to aspergillus infections and many other immunologic conditions that I am not smart enough to understand. She actually was just elected the chair of the Clinical Immunology Society's Early Career Immunologist Committee, which she's going to be starting next month. I say all this, obviously we are really lucky to have Kelly here at MUSC. And on a side note, and this is a personal note for me, Kelly is actually now one of my personal physicians. So for those of you who know me, I'm a little bit of a weirdo when it comes to my medical history, specifically dealing with some allergic challenges over the past few years. And I'll admit, it's really funny how the field of allergy immunology works. So I just told you, I recruited Kelly into our pediatric residency where she exclusively took care of children. She went on to the NIH, and I was referred to the NIH as a patient, where immediately Kelly became part of my medical team at the NIH. It was a little bit weird. And so I saw her there as a patient, and now Kelly is my personal allergist and immunologist here in town. I guess it comes full circle. Funny how that works. Anyway, I am incredibly proud to call Kelly part of my first recruiting class, my colleague, my personal allergist, and my friend. Everybody help me in giving a nice warm welcome to Dr. Williams.
Thank you. That was a lovely introduction. Okay. I'm sorry. Am I supposed to show that? Okay. I guess you're doing inpatient opioid provider dosing study. Okay. So the goal of my talk is to get all of you guys to think a little bit more about primary immune deficiency, because these patients, while they certainly can have very rare diagnoses, they were walking into your clinic, your ER, the hospital, much before they walk into my clinic. And so I need your help to think about them so you can put a referral in and send them my way. So they're zebras. We learned about them maybe a long time ago in medical school, but they are here and we are all taking care of them. So two quick disclosures. I'm on a medical advisory board for RMS Medical Products. They provide a pump for IG. And then I'm going to be talking about some off-label use for several different immunomodulators for these rare diseases. So some learning objectives. To recognize the classic clinical presentations of primary immune deficiency. To describe how the clinical presentation of primary immune deficiency has evolved over the last 5 to 10 years. And to discuss the importance of identifying a genetic cause for immune deficiency, and specifically how this impacts our medical management for these difficult and complex patients. So back in the beginning, The first immune deficiency was described in 1952, so just under 70 years ago. And it was a case of a 9-month-old boy who was found to have recurrent pneumonia, upper respiratory tract infections, and ear infections. Typical 9-month-old boy. Unfortunately, he had no detectable serum immunoglobulins, and it wasn't until 40 years later where his genetic cause was described, and that was a BTK gene defect as the causative problem, leading to X-linked agammaglobulinemia. It's the most profound humoral immune deficiency, and something that may have shown up in boards one time, but it's an important diagnosis because it really showed us that you can have a problem. We treat it for 40 years. They may or may not have died in that time, but once we identify the actual problem, we can better manage their disease. So BTK is a gene that's very important, and a protein that's important in B cell development, and so it leads to an arrest of B cell development, and this causes patients to have no mature B cells, no plasma cells, and then they can't make antibodies. So they have small lymphoid organs, so on exam you wouldn't see tonsils, you may not see, or you shouldn't feel any enlarged lymph nodes. And commonly, from a clinical perspective, they have recurrent bacterial infections, pulmonary infections, specifically encapsulated bacteria cause pyogenic infections, and they can have a really severe presentation of enteroviral infections, both meningitis at an early age, recurrent enteroviral meningitis, and even like enteroviral or echovirus myositis. That's a pretty classic one. And so this is the first case we ever had for immune deficiency. So moving on to another case from the early years is a case of this boy, David Vedder. He, also known as the bubble boy. In 1971, he was born and immediately put in a bubble. And the reason for that was because his brother, who died before him, he died at age 7 months from a severe infection and was later found to have X-linked severe combined immune deficiency. And so nobody knew exactly if David would have this, but once he was diagnosed, he was immediately put in the bubble just in case, and they confirmed his diagnosis by lymphocyte phenotyping or flow cytometry, and they put him in the bubble until they had a plan. So precautions were taken early. He lived in a bubble for 12 years. Here's a picture of him with the late William Scherer, who passed away this past year, and he stayed there until he was transplanted. Unfortunately, he ended up developing EBV lymphoma 4 months after transplant and died. But I use this as a case to show you we had a problem, we identified the problem, we didn't really know exactly how best to manage it, but we still were able to keep him alive because we knew about the problem ahead of time. And so that's kind of, I want you to think about that as we talk about some of these other cases. So this is our case of a few interesting cases, I think, from way back when. And before moving on to some more cases of now, I just wanted to give everybody a refresher about the immune system. So there are some pretty big components of the immune system. We have the innate immune system, which is activated early, hours to minutes, or minutes to hours after we're threatened by anything. And then we have the adaptive immune system, where we have actual cells that are there to help create a bigger response. So problems in any of these areas can cause disease. The most common we'll have is an antibody problem, and that's a humoral defect. You can have a T cell problem, which we consider cellular defects. You can have a combined defect, so a T and B cell problem, or other commonly things. And the most common problem in the innate immune system is a phagocytic problem. And so any of these things can cause disease. You can also have complement deficiency, and that's another area in the innate immune system. So what's primary immune deficiency? Primary immune deficiency diseases are a group of rare chronic disorders of the immune system that result from one of two big problems. Either you don't have enough cells to fight infection, so you have an absent or reduced number of cells, or the cells you have don't work, or they don't work appropriately. So we have absent or reduced function of these immune cells. And then this leads to increased risk for recurrent or severe infections. And so that's this is how I focus most of my life, or at least on my immune deficiency days. Back when I started training, we had early classifications of primary immune deficiency. It was a pretty rudimentary way to think about things, but it was a way in a system that I learned when I started training is think about 4 big boxes. We have a humoral problem, we have cellular problems, we have complement defects, and we have phagocytic stuff, and that is responsible for most of the infections. And so I was trained to ask my questions in my history to really try and check off each box. if I ask a few questions about this, or this, I can say, yeah, your T cells are working fine, your B cells are working fine. I'm really only worried about this type of problem. And so this is a good table, I think, for you guys to start thinking about when you are asking your questions on histories for people who are coming in septic, or you're worried about their infectious history. We ask questions specifically targeted at the types of infections. So is it just recurrent sinopulmonary infections? Then I get worried more about B cell problems. If they're having recurrent sepsis, then I worry more about, complement problems or T cell problems. And then it's important to find out what types of pathogens. So I really stress getting cultures on patients because it's important. A recurrent or chronic diarrhea is one thing, but if it's chronic diarrhea from crypto, that's another thing. If it's, there's some certain pathogens like Serratia and Burkholderia that are pathognomonic or classic infections that are there with CGD. And so those type of things quickly can lead you down to whatever problem you're thinking about. So over the last 5 to 10 years, our thought process has evolved a little bit, and that's because we now know a lot more about the pathogen and the immune susceptibility and what cells are involved in each of those pathways. So this has offered us a little bit of an expansion to the clues to the immune defect. So just taking that last table and kind of showing how we talk about it now, I put it into categories of T cell, B cell, NK cells, neutrophils, the mononuclear cells, and complement, and we can kind of think, okay, if they have this problem and this problem, where are we going? If you notice, there's also this whole nother category now of mycobacterial disease because that has really expanded, and we get a lot more worried about that. And there's a whole actual new category of primary immune deficiency called Mendelian susceptibility of mycobacterial disease, and so I worry specifically about defects in that area. So that pathway, this first table I showed you was from when I started fellowship, 2012, and how this is about 2017 or 16, we really came up with a table more like this. So just talking about immune deficiencies, I just need to remind everybody, these are rare. The incidence is 1 to 1,200 to 20,000. The 1 to 1,200 is the most common thing called IgA deficiency, but it's rare. These are rare diagnoses, but they're there. More common in men than women, and that's because of the X-linked diseases. The distribution of them I already reviewed, but for the most part, these are mostly, the large majority are humoral or B cell deficiencies. And then we have these combined T B cell defects, and then you have a variety of other things, cellular and phagocytic defects. So just to show you how much my field has changed in the last 20 years. So there's a group called the International Union of Immunologic Societies. They were the first people to ever come up with a chapter that described primary immune deficiency. And their first chapter came out in 1995. And it described a whopping 28 genetically described immune deficiency disorders. 20 years later, that number went to 300. When I started fellowship in 2012, it was 212 genetically described immune deficiency disorders. And now here we are, we're already over 360 in 2019. So this is just to show you how much the field has changed and how it's important to keep up with the field and how it's important to continue to ask the questions because we know there's a lot more diseases out there that we have to think about. So it's exciting for people like me, and it's hopefully exciting for people like you because now you can just diagnose a lot more things, or at least you can be a part of the diagnostic pathway. So we're going to talk about why that expansion's happened later when we talk about genetics, but we're going to get back into some cases. So these are all cases of patients that I followed over the last few years, either at my fellowship or here at MUSC, and I think they're good descriptions of interesting cases that you wouldn't think of as immune deficiencies, but show the changing face of immune deficiency in the last 5 or so years. So it's a 15-year-old female who presented to her primary care clinic, and she presented with petechiae and some mild cervical lymphadenopathy. Initially thought to be viral, it was followed, and then she was, history showed that she had recurrent ear infections in childhood and had 2 sets of tubes. She had a history of ITP at age 4 that was also post-viral and was treated with steroids and IVIG. She eventually made her way to an immunologist and was diagnosed with hypogammaglobulinemia and then CVID, and she's on IVIG currently. She has chronic diarrhea, and that developed at age 10 and was diagnosed with IBS. And she was referred to hematology for her current problem and diagnosed with autoimmune thrombocytopenia. So these are all things that could have presented either to the ER, to your clinic at some point, but over the years evolved into a different picture. So then, a year afterward, she developed some headaches, vision changes, and was evaluated for possible development of MS. She was found to have brain lesions on her MRI, and eventually that was biopsied and showed some lymphocytic infiltrates. And then she had further studies done because of a chronic cough and had granulocytic lung infiltrates, and then she was diagnosed with enteropathy of her gut. So we have some ILD-like picture with her lymphocytic infiltrates in her lungs. We have the enteropathy and then her very prominent brain lesions. Her family history was quite interesting. Her dad had a very similar history. He had lung and GI infiltrates. He had CVID. He was on IVIG as well. He had splenomegaly and cytopenias. She had two older sisters. Both of them had autoimmune thyroiditis. One sister had chronic sinusitis, one of those same sisters. And then she had a younger brother who had recurrent ear infections, and he also was diagnosed with celiac recently. So unifying diagnosis here is something called CTLA-4 haploinsufficiency. CTLA-4 is a very important inhibitory regulator on Treg cells, and it's important for immune tolerance. So a problem in that defect means you have poor inhibition and then you get uncontrolled immune tolerance. So this is a haploinsufficiency disease. So you have a heterozygous germline mutation, only one copy, so you have one functioning copy, but it's not functioning greater than 50%, so then you actually get true disease. It is essentially loss of function. Clinically, these patients present with uncontrolled immune tolerance. They get these increased lymphoid aggregates in a variety of different organs. The brain and the lungs are very common. You can get these nodules that form in the lungs as well. And then they have significant GI enteropathy. It usually presents with chronic diarrhea. They have hepatosplenomegaly, and they have pretty significant lymphadenopathy. And so these are all examples of lymphoproliferation. This is a different patient, but I took some other images from a study, but just to show their lung disease. It is severe. And then the brain lesions are very prominent. And then obviously, hopefully you can see that spleen is almost the same size as that liver. And so clinically, from an infection standpoint, they have the normal recurrent sinopulmonary infections that we see with people with hypogam or B-cell defects. They have recurrent C. diff, and they have increased susceptibility to viral infections in EBV and warts. So just looking at a different cohort, but this is a nice table that really shows the majority of these patients are presenting with GI problems and hypogam. And then, any of the GI people know you can have hypogam secondary to your losses, but these people really should be evaluated from a primary immune deficiency standpoint, especially if they have lymphoid aggregates in other organs. So you'll also see there's lots of autoimmunity here. So as you saw from the family history, you can have variable penetrance. It can look completely different in each of the levels of their family. But taking a good family history is important. So moving on to another case, this little girl was followed here for many years and recently diagnosed. She's a 7-year-old African-American female who first presented with recurrent oral ulcers. She presented to her primary care doctor and then was referred to our dental clinic. And she had ulcers that were clearly evident. They were swabbed and found to have candida. And she was treated. They went away. The ulcers came back. She had candida again. By age 9, she was seen by our ID team as well as our GI team because she ended up also having esophageal candidiasis. So she was diagnosed with recurrent oral and esophageal candidiasis. It was always responsive to fluconazole. It would go away, but mom would say, every 3 months, we'll get it again. Every 3 months. And this has happened for 2 years. Her EGD showed gastritis and also some ulcerations and candidiasis. So some other things about this patient. She had a history of recurrent and difficult to treat thrush in infancy. Mom said once she was off the bottles, the thrush went away completely. She didn't have any problems until age 7 again. She had chronic ear infections that started at age 6 months and had 2 sets of tubes. She also had recurrent and prolonged upper respiratory tract infections lasting 2 to 3 weeks at a time. She had a 10-day hospitalization for RSV at age 18 months. She had 1 pneumonia that was chest x-ray proven in her lifetime. And she was followed by Dr. Wine Lee for diffuse flat warts. These are images from Dr. Wine Lee. She had them on her face and all over her legs. And she was also followed by Dr. Paolo for Hashimoto's thyroiditis since age 4. So a weird mix of lots of things. She has STAT1 gain of function mutations. So STAT1 is an important transcription factor for the immune system. It's really important in cytokine signaling, specifically IL-17, and it's really important for the immune system and making sure that the right cells are getting to the right places. So this is the JAK-STAT pathway. So JAK and STAT, those are the transcription factors, and it's important just to show that interferons are going through this pathway. So specifically, gain of function means that you have a mutation that causes increased activation of that pathway. So the example here, I guess I'll use this one. So here we have the control. This shows normal STAT1 function, and the function's all based on these phosphorylations of the gene. But there are some patients who, if they're hyperphosphorylated, you get these extra phosphoruses here that then cause increased function of that of STAT1. So then basically you're flooding and going through this whole pathway, and that can cause lots of uncontrolled disease. What does it look like? The chronic mucocutaneous candidiasis is a hallmark. Most patients have this. This is the first thing they'll present with both early in life. It can present at age 1. It can present at age 10. But these people usually have growth problems because of the CMC when in infancy. More than 50% of all cases of true defined CMC is usually related to some type of defect in the STAT pathway. You can also have disseminated coccidioidomycosis, so disseminated histo. You have recurrent sinopulmonary infections, and that's because of a class switching defect in the B cells. You can have systemic or atypical viral infections, specifically most commonly are HSV, VZV, and CMV, but you can have a variety of these other ones, and that's because STAT1 is really important for NK cell function. So our patient here had flat warts that were quite diffuse. And you have significant autoimmunity that starts really early in childhood, and that's because of poor immune tolerance. So these kids are presenting with diabetes before age 5, thyroiditis before age 5. They have lots of skin problems. They can have other cytopenias. The typical STAT1 gain of function patient is going to have autoantibodies that are positive. Just the serologies are positive in at least 3 or 4 organs, and they will develop before age 10 at least 3, usually by their teenage years is what we say, they'll develop at least 3 autoimmune conditions that are clinically relevant. So the important thing is diagnosing these kids early because we're trying to prevent the development of all of this. They also have cerebral aneurysms or increased risk of those, and we're not really sure why, but that's being further explored. So our last case is another little girl that I followed. She's 7 years old with Vietnamese female who presented to her primary care doctor with chronic wet cough. These patients present to me a lot, and I know to our pulmonary group and ENT group a lot. So she had wet cough for 5 months. She was found to have persistent cervical lymphadenopathy and as well as axillary lymphadenopathy and some mild splenomegaly. Her chest x-ray was done repeatedly and just showed some viral process, peribronchial thickening, no pneumonias. She was evaluated by ENT. They thought maybe it could be adenoids, but those were not taken out. Pulmonology had seen her. She was seen by allergy and immunology eventually as well. Each time she was treated initially with steroids, then she was treated with amoxicillin, augmentin, ceftonir, azithromycin eventually. And every time she was on antibiotics for a really long time, she got better. But as soon as she came off, her cough would be back in 3 to 5 days. She had a pretty thorough infectious evaluation, and the only thing that was relevant on her initial infectious evaluation was that her EBV viral load was 6,000. So she continued to be followed by pulmonology and was found to have moderate bronchiectasis on CT. She did have a history of recurrent upper respiratory tract infections and ear infections since age 1 and had 1 pneumonia in her lifetime. That was last year. She was bronched and had copious S. pneumo as well as some pseudomonas. She was also noted to have this really interesting mucosal nodular hyperplasia that when they biopsied it was mostly B cell predominant. So that's really hard to explain, so I'm going to try and show you. This is a 3D video from one of my colleagues of her bronch. So all of those bumps are mucosal nodules in her airway. Really unusual. So unusual that he also published this in the New England Journal as like interesting clinical images because you don't see that usually. Okay. So her immune evaluation showed some CD4 lymphopenia and elevated CD8 cells. Most importantly, she also had like a hyper IgM phenotype, which was really unusual, and she had normal IgA and just low normal IgG. She continued to have this low-grade EBV viremia, and so we were following her for that. And eventually, 2 years later, she was diagnosed with EBV lymphoma. Her family history was also significant for 2 other EBV-associated lymphomas. And she was found to have a mutation in the PI3K pathway. And so there's two different mutations that we now know, but her mutation was in the P110 delta. This pathway is important for tumor genesis, but also for just lymphocyte biology, specifically T cells. So similar to that STAT pathway, we have this PI3K, which is really important. It gets phosphorylated, and then it causes a downstream effect for this AKTS6 pathway. And so a defect in this pathway, again, leads to poor immune tolerance and massive lymphoproliferation. So how do these kids look? They have lymphoproliferation. They look like the CTLA-4 patients. They look like ALPS patients. They look like cancer patients. And it's important to know that these nodes can be benign for many years, and then they're lymphoma. So you have to really follow these patients closely. They can have chronic lymphadenopathy. They have splenomegaly. They have this very characteristic mucosal nodular hyperplasia. It can happen in the lungs, and it can happen in the gut. Here are some pictures of it in the gut. And they're increased risk for developing lymphoma. You have to follow these patients carefully because they're fine until they're not. And so the lymphoproliferation is profound. They also have significant autoimmunity, similar to the ALPS patients and the CTLA-4 patients. They have autoimmune cytopenias. They might just have hemolytic anemia, and then all of a sudden they have petechiae. They can have PSC. And they have infectious profile is very similar to some of those other diseases that I've described. They have recurrent sinopulmonary infections. Most of them eventually get a diagnosis of CVID. They have EBV and CMV viremia, and that's very classic and can be low grade until it gets really bad. But usually we just follow them. That's 10,000 or less, but it's consistent. And we can see upticks in that depending on the control of their other disease. They also have recurrent dental abscesses, and they can have other recurrent viral infections. Immunologically, they have CD4 lymphopenia, especially naive CD4 lymphopenia. They have a really poor maturation of their B cells. So they have this tons of B cells that are these transitional B cells. They get stuck before they can become mature B cells, which means that they don't have memory B cell defect, and they have poor class switching, which means they get sick a lot. They also can have poor vaccination response. So switching gears briefly, I just want to talk about genetics and genomics, because genomics and the way that our field of clinical immunology has changed in the last 5 to 10 years is really because of the changes that have happened in genetics. I have a disclaimer, I'm not a geneticist. I just think about genes a lot when I'm thinking about immune deficiencies and inheritance patterns, but I think it's important just to kind of put it into perspective for you. So only 10 to 12% of human coding genes are involved in the immune system. That's only like 2,000 genes that are linked specifically to the immune system. And of those, about a third are related to the adaptive immune system. That's the T and B cell stuff that I was talking about. And the rest of it's really the innate immune system, which is a minority of our immune deficiency diseases. To date, we know now in 2019, there are greater than 360 monogenetic diseases of the immune system that cause deficiency or dysregulation. Most of those result from a loss of function, but there are at least 7 that are either loss of function or gain of function. So for instance, I talked about STAT1. STAT1 deficiency looks so different than STAT1 gain of function. And that's just because these genes are really important for the immune system, and problems can go either direction. So just a few words about techniques. So very rudimentary, but the very early first diagnosis with BTK and all these other immune defects was, we have a gene. Is there a problem in that gene? It's very simple. It's a very simple way, direct gene sequencing. Do you have a mutation in this gene? This is a simple way of looking if there's a problem. It's simple and sensitive and widely available. It's pretty expensive because it's labor intensive. You look for any mutations in that one gene. And it's really dictated by me. I say, I'm worried about this disease. Look at this gene. I base that on clinical history, lab findings, and family history. There's very little utility in gene discovery because you have to know the gene you're looking at. So we use this to confirm some diagnoses. So if I'm worried about an X-SCIT or an X-CGD, then I will do that to confirm. And this is just to show that you can have a carrier status and you have a patient and then you see a mutation. But we don't use that when we're trying to look at a handful of things. Hopefully for my cases, you saw that there's a lot of overlap in some of these clinical phenotypes. So because of that, we're looking beyond one gene. There's a variety of different mechanisms to do that. And a very common and simple way is next-gen sequencing. I use this a lot. I know rheumatology uses it and some other fields also use it. But specifically, it's looking at a targeted panel of genes. It has high throughput, doesn't take so long, 2 to 3 weeks. It's very cheap compared to Sanger sequencing, and it's non-biased. I'm looking, for instance, if I send a gene panel of, which looks like this, for 207 different primary immune deficiency genes, I'm looking for common mutations in certain areas of that gene. It's not looking at the whole gene, but it's looking at where I know there's disease from those genes. And it's very helpful. But it's not the end of everything, because deletions and duplications can miss some things, and so you have to think beyond that as well. There's whole genome sequencing, where it evaluates all coding and non-coding base pairs. There's whole exome sequencing, which is only looking at the exons. And that's estimated to pick up about 85% of disease and disease-causing mutations. These two processes take a lot longer, and they're very labor-intensive to look through all of the hits that you get, but can be very helpful, especially when families are involved and you're looking to see if certain defects are really causative. So this is just another rudimentary way to look at the whole genome versus exome. So these are all so helpful for people like me. But why is it important to reach a genetic diagnosis? Patients want to know. That's a big thing. It helps us establish a definitive diagnosis. It brings a lot of comfort to them, and they've been soul searching for many years. And also it's helpful for people who are caring for them. It also helps us identify patients at higher risk for malignancy and thus closer surveillance. So those patients with PI3K, I tell them something completely different than I tell my patients with like a STAT3 gain of function. And so it's important to know, like, we need to check you all the time. I need to do lymph node exams. Someone needs to do them every 2 months, because we're trying to prevent them from developing malignancy. Also, it has implications for deciding on treatments later on. And so this also provides opportunities to screen others in the family who may be at risk, as well as provide family counseling. And it gives us understanding of specific disorders and the genetic mechanisms that are causing those problems. And most importantly, it can identify new potential therapeutic targets. So specifically, when I find a defect in a pathway, if there's a drug out there that works in that pathway, I can think about it and try to really change the view of that disease. So what are our tools right now currently to treat immune deficiency? Our goals are to identify infection and treat it, to prevent future infections, to prevent future complications from them. So in humoral deficiency and dysfunction, we have prophylactic antibiotics and we have IG replacement. Not everybody qualifies for both, and insurance companies are making it harder to give people IG, but we can do it. If you have certain diagnoses, we can offer that by IV or sub-Q. For cellular deficiencies, we really can only offer prophylactic antibiotics. There's not much out there. And then for immune dysregulation, we can offer a variety of immune modulators or immunosuppressants to try and downregulate pathways that are causing problems. And then when applicable, we have stem cell transplant and gene therapy that are very helpful in certain diseases, and that list of diseases is expanding every day. And so those are all really helpful for treating disease. However, not everybody wants a bone marrow transplant, and there's lots of complications that come with that. So if there are other things that we can put in our toolbox to use, we would like to. So just bringing us back to each of these cases briefly. The case of CTLA-4, there's a drug on the market called abatacept or Orencia. It's a soluble fusion protein, and it specifically works on the extracellular domain of CTLA-4. It's right now approved by the FDA for rheumatoid arthritis, psoriatic arthritis, and JIA. But people are using it for immune modulatory effects in many different diseases. It's Jimmy Carter, and they're using it in fighting his cancer, his melanoma. And so specifically at the NIH, we were looking at a variety of different drugs to see if they can help in these pathways where we found defects. So abatacept specifically can rescue the T cell hyperproliferation phenotype. So here we can see this is our extra immune tolerance and hyperactivation before therapy, and afterward, by using this drug, it's completely normalized. Just to show you a clinical picture, this was a kid with a really huge spleen that was reduced to about 60% after 4 months of treatment. So that's a great example of using a very specific therapeutic target in a disease. Sirolimus is a little bit less specific, but also can work in the same pathway. It's an mTOR inhibitor. It's used for IL-2 production and blocks the activation of T cells and B cells. And specifically, it helps inhibit the Th17 cells. It's used in lots of allograft rejection. And we've also used that in CTLA-4 specifically with a brain lesion. So this brain lesion literally melted away with 6 months of sirolimus. In our STAT1 gain of function patient, specifically this patient I've been following for a while, and it's important. So I told her, yes, we've got a genetic diagnosis. It's been great, but I'm trying to prevent you from getting sicker. And that's our goal. So specifically, her fungal infections, since starting her on prophylactic fluconazole, she has had 0 recurrences of her CMC. And she's on Plaquenil to kind of prevent, or in hopes to prevent, the development of lupus, because she has some pretty significant autoantibodies there. And I've been working very hard to try and get her insurance to approve off-label use of a JAK-STAT inhibitor called ruxolitinib, specifically because it's been shown to improve the autoimmune disease aspects in STAT1 gain of function, and also a little bit with CMC. So just to show you that, again, this drug specifically is really neutralizing our Th17 and immune tolerance, and that is allowing for less dysregulation. So this off balance goes to more of a balance. So I'm in my 3rd appeal, so hopefully we'll get that approved soon. But there was just a case report that came out specifically looking at this in 3 different patients. And one of these patients who was in the honeymoon period for diabetes at age 4, who had STAT1 gain of function with her CMC, she's never needed insulin since she's been on this drug. So it really can control the autoimmune phenotype. A study of 15 patients just came out looking at stem cell transplant in STAT1 gain of function patients. And while it can be curative, the engraftment rate was not great, and the overall survival rate was not great. And that's because of all the viral diseases that these can cause severe significant disease. So we're not super enthusiastic about that at this point. In our last case, the PI3K gain of function patient, specifically, there's another drug on the market, leniolisib, that is in development for Sjogren's and used in a clinical trial right now at the NIH. It's specifically a selective oral inhibitor of PI3K gain of function. So it blocks exactly the pathway that we want to block, because this is the pathway that's causing immune dysregulation. Sirolimus also blocks this, although in a non-selective way. And so they've done, there was one trial just looking at the monoclonal antibody, but then now looking at comparing sirolimus and the biologic, and looking at spleen volume size compared to previously. And we have good results with both of them. These are unpublished, but hopefully will come out soon. And back to our little girl who had the mucosal nodular hyperplasia post-therapy. All of her nodes, most of her nodules have melted away. And this was after 6 months of therapy. So hopefully I've convinced you that knowing the diagnosis or gene can be very helpful in managing these patients. Just to recap, there was those 4 big rudimentary classifications, and I just want you guys to think about those, but also think about the newer areas of immune deficiency that have expanded, specifically the diseases of immune dysregulation. So I use those words often, and my husband tells me people's ears just turn off. But I think it's important to think about, if you think someone's body is not responding the way that it should be, then you should tell someone and get referral, or just discuss the case with someone interesting, or with someone who thinks it's interesting. Autoinflammatory disorders, there's lots of overlap now between my field and rheumatology, and so that's a really great area of expansion. And then we also know there are phenocopies of PID. So for instance, that IL-17 that I was telling you a problem with STAT1 gain of function, they have autoantibodies. You can also have a similar phenotype, and we call those phenocopies. So when do you call me? Or when do you call immunology? Just a few things of when to think about immunology. If you have recurrent sinopulmonary infections, so not just like one viral infection or one cold a year, but like when you have lots of infections within a year, 2 pneumonias in the same year, you should talk to somebody. If you have 2 sinusitis within the same year, you should talk to somebody requiring antibiotics. And so 4 to 6 ear infections within the same year, you should just consider it. Especially if the ear infections are not improving after tooth placement. Also, if you have severe infections with common pathogens, you can have deep tissue infections or unusual sites of infection. So liver and brain abscesses are certainly unusual. Opportunistic infections, specifically the mycobacterial disease, also recurrent salmonella, live virus vaccine associated illnesses, definitely give us a call. And patients with chronic diarrhea, failure to thrive, or refractory enteropathy should be considered for a consult. Also, people with early onset autoimmune disease, diabetes at age 1, diabetes at age 2, those are pretty unusual, and we worry about, Treg dysregulation. And also difficult to manage lymphocytic infiltrates. So this says when to call. I formally transitioned to the Department of Pediatrics in January, and so I have a little bit more actual dedicated time to do inpatient consults. That's not to say everybody needs an inpatient consult, but if you're not sure, just give us a call and I'll say, this sounds like I should be seeing them outpatient versus inpatient. The preference is to do an immune evaluation when their immune cells are going to be normal. So if they're really sick in the hospital, you're going to have really abnormal immune labs. And so sometimes we don't need to do anything immediately, but I should see them in 2 weeks. Just give us a call and we're happy to help manage that. But I am here a little bit more now for inpatient consultation. So again, just give me a call and we can talk about that. Most immune evaluations are done in the outpatient. And so to tell you how to do that, you put an ambulatory referral to immunology. We're trying to keep them very specific because of the central call center and confusion. There's a different referral for immunology and a different referral for allergy. I have specifically different clinics for both of those things, and my immunology clinic, you can specify the provider or their location if you have a preference. So we have 2 locations. So starting April 1st, right now I see people in West Ashley, but starting April 1st, my immunology clinic is going to be at the Sami Medical Pavilion, so out in North Charleston, and it's going to be specifically dedicated to immunology all days. I will not be seeing, I don't have capabilities to be seeing allergy patients there at that time, so it's just immunology. And Maria Streck in Mount Pleasant sees mixed allergy and immunology, so each day she sees both allergy and immunology. She has clinics for 3.5 days a week. So you can specify location for people, or they can say first available, or you can specify each provider. And then you can always contact us via pager, email, or Epic message if you're just not sure or anything urgent. We would rather you call and ask than not, and we're happy to help you. So think about them because they're there. That's it. Any questions? Yes. There is also a tremendous difference that every time we get it's a failure of our and there have been some issues with a immune response and yes. So there's definitely, you're talking a lot about the TLRs and also just even the phagocytic defects and the NK cell defects. Those are all definitely expanding as well, and it's really hard, and especially, as I showed, 2/3 of those genes are really involved in the innate response. Those are harder to identify, I think, and there's very special labs that we can do or send to certain areas. But again, when patients are presenting with those type of diseases or infectious pathogens, just let us know and we can try and connect them to the right people. But yeah, there's our laundry list is long. Yes. Yeah. Yes, so I'm happy to. I'm giving, I think, your fellows a lecture on May 7th. I've talked to Julie before just about the TREC skid and the protocol for that, but I'm happy to help with any of those other things as well. We have a patient right now in the NICU that we're following and who has chronic diarrhea, really, and that's really unusual for that age. But yes, from an infection standpoint, it's hard because especially the really preemies, like it's like, well, how much leeway do we give them, right? And we do give them some, but really unusual infections should be evaluated. CRISPR? Yeah. In certain diseases and certain labs, it's definitely coming up a lot more. I don't have those capabilities right now, but yes. Yes. Yeah. So in that case, usually I would just say, if you're not sure and you're kind of like, well, I just don't know, give us a call and we'll be like, oh, that would be really helpful right now. Otherwise, not so much. Yeah. And just like I told one of the residents, like, just call and I'll say if this would be helpful now or not at all. It's just going to cloud the picture. I will just say as a caveat, like all of these 3 cases, like I follow 2 PI3K gain of function patients here in Charleston. I follow 1 STAT1 patient here in Charleston, and I have 4 CTLA4s. So they're all here, even though they're rare. So definitely think about them.